Good evening.
Sarah, what can I say? I just in awe of the work that's gone on. And well, I've got a couple of questions to ask, and then I'm going to start using the ones that people are submitting. You talked about the fact that you'd been working on this idea of disease X for a while. And I was reading that on New Year's Day, you became aware of what was going on in Wuhan. But I'm still struck by how fast the decision was made by your team to absolutely go for developing a vaccine. And I just wonder how difficult a decision that was to kind of press go on a project this big. Could you talk us through that?
It was a little bit difficult because as I said, we didn't feel that we were fully prepared. We'd had some plans that we wanted to work on. We hadn't been able to put them into place. We hadn't been funded to do the work that we wanted to do. So we knew we had a technology that was suitable, but we hadn't done all the optimization to really cut out any unnecessary time in the early vaccine development. But then we had a few days to decide, are we doing this or not? Because what we did know was that if you're going to go, you have to start straight away. As soon as the sequence was available and we were waiting for that, we would start the vaccine development. But I knew from thinking back to what happened in Ebola, we thought we did a great job there with the early clinical development. And there we didn't have to do the vaccine manufacturing, the very early development, the testing in animals, that had already been done. The vaccine had been manufactured. Our job was to help get it put into the vaccine vials and tested, and then do the clinical trial and get it to West Africa so that it could go into a phase 3 trial. And we did our part of that very quickly. And the early part had already been done. So it was not a particularly difficult thing for us to have to do. But then it just stopped. And things, people needed to work out how to move to the next stage, who's going to work with who, what was going to happen. And so that was in our minds when we were thinking about this vaccine project. If you're going to achieve anything, you have to plan all the way to the end of the project, all the way through to vaccine licensure at a very early stage. And that was the part that was really most challenging. It wasn't that we hadn't done all of these things before, but we now had to do them all at the same time. And we had to think about who was going to manufacture this vaccine and who was going to do the commercial supply to get it around the world. We needed a partner, and we needed a manufacturing process that we could transfer to that partner, and we had to work on that at the same time as we were working on the animal studies and writing the application for the clinical trial. So everything was happening at the same time, and that was what was really very challenging.
Make every little moment count. Fine chocolate, luscious caramel, new caramel squares from the Lindt Mustard Chocolatier.
And obviously, the pandemic was developing very fast. Politically, there was a lot of issues and tensions around it and the way different countries were handling it. Were there any points, once you embarked on the process of developing this vaccine, of real difficulty, of whether it was major disagreement or anxiety about, is this going to go the way we need? Because obviously I know the British government did absolutely back it, early on at a key stage, but I'm interested in, was there a point where it was worrying about how you would proceed?
In the first few months, it was really difficult to get this moving at the speed that we needed to, because I think we had to, we're a university and universities don't make and sell vaccines. And we had to find a partner to work with. And it was difficult to persuade people that we really could do this, that we really could do the early work ourselves and then work with a partner, which turned out to be AstraZeneca, to take over the vaccine manufacturing and to take over the eventual supply of the vaccine. And we were trying to convince people that this was possible, we could make it work while we were trying to do the work. So again, it was just doing everything at the same time. By the time we got to about May, we had UK government funding, we had a partner in AstraZeneca, and from then on, it was still an awful lot of work to do, but we knew we had everything in place then to move on with the project.
I'm going to start taking some of the many terrific questions that are coming in. So Andrew Barrow asks, why did SARS and MERS not become pandemics in the way that COVID-19 has?
Well, I think they're not as transmissible between humans. We've seen now, particularly with the UK variant that arose of SARS-CoV-2, it spreads very, very easily between people. That's not really the case with the first SARS virus. With SARS-CoV-1, people didn't transmit the virus until they already had symptoms. So it's possible to know that you're infected and quarantine before infecting anybody else. That made control a lot easier, whereas with SARS-CoV-2, we know that people get asymptomatic infections and can still infect other people. That makes it a lot harder. With MERS, it could change, it could adapt. If you have enough infections in humans with the coronavirus, it probably will adapt. So we really need to try and keep the lid on MERS so that it doesn't go the same way.
A follow-up question then, don't have a name with it. Will the COVID-19 experience get us ready for the next pandemic?
Well, I really hope so. I think we've learned a lot. We've seen some things that work well. We've seen that a consortia of groups working together can really achieve rapid vaccine development. Within the UK, we'd already had the initiation of the Vaccines Manufacturing and Innovation Centre. So that's a research vaccine manufacturing facility, essentially, which was starting to be built. Sadly, it wasn't ready to use in time for the pandemic, but it will be ready by the end of 2021. So whereas we had a lot of problems last year, we made our own small batch of vaccine for the phase 1 trials, and then we needed to get the next lot of vaccine made to continue clinical development. That was a problem for us. If VMIC had been up and running, ready to manufacture, that would have made our lives a lot easier. So there are certain things like that that are being put into place that will help, but we still need to keep thinking about all the challenges, where we can save time, and how we can make this work as efficiently as possible.
Thank you. Laura Picorni asks, why are bats so often the reservoir for zoonotic viruses?
It's interesting, isn't it? I mean, bats have slightly odd immune systems, and they seem to tolerate infections with lots of different viruses. They get infected with rabies-like viruses as well, and it doesn't make them ill. But the viruses are quite happy living there. Viruses don't do well when they kill their host, because then they've killed the golden goose, if you like. But they seem to coexist quite easily with bats, and there are lots of different viruses that we find in bats that then can start to infect other species and ultimately us.
Do you think there is a reason to be concerned about this claim that climate change and the kind of encroachment on wildlife habitats is going to make pandemics of this kind more likely in future?
Anything that increases contact between wildlife and humans is going to make zoonotic infections, or this spillover, more likely. And it doesn't need to happen very often. In the Ebola outbreak of 2014, that was one person who got infected from a bat, and then it spread and killed many thousands. So if we have deforestation, humans encroaching into different areas, wildlife coming into contact with them more, this will happen more often.
Thank you. Christina Patterson raises a question which I wanted to ask as well, but let me put it her way first. Absolutely wonderful what you've done, first of all. I think a lot of people are commenting on that. What's the data currently showing about long COVID? And she says for those who've had 2 doses of the Oxford vaccine, but I think there's a real anxiety about the impact of long COVID in general. Do you have any observations about that? And yes, specifically, how far the vaccine can affect that?
Well, the vaccine will prevent infection. So people who've been vaccinated aren't expected to get long COVID. I mean, there are some infections in people who've been vaccinated. They tend to be very mild and they resolve very quickly. So I suppose we still need more data to see if anybody who's been vaccinated ever gets long COVID. But we would expect, because we're reducing infections to such mild disease, it's probably very unlikely to happen. If you've already got long COVID, the vaccine isn't going to help you, most likely, because what you're suffering from is not the viral infection itself, it's the after effects of that infection.
Thank you. Right. This is one from someone with the name HBs. Thank you for such a fascinating lecture. I was wondering if the absence of any obvious reaction to the COVID-19 vaccine, such as chills, pain at the injection site, etc., signifies a lesser immune response, or if that's just perfectly normal.
No, it doesn't. So the reactions after vaccination vary quite a lot between different people. And it doesn't mean that you not make a good immune response if you don't have a reaction. It's just people are different. Some people don't really react at all and still make a very good immune response.
Thank you. Your vaccine, so this is a question from Don Fuller. Your vaccine is injected. What are the pros and cons of a nasal spray vaccine?
Now, our vaccine is injected because we needed to move quickly. We had data on using this type of vaccine by injection previously, and that was the only way to go fast. We are considering a formulation that might be different, that might be a nasal spray or even a tablet form of the vaccine. These are things that will take some time to develop because we need to think about different formulations. We would also like the vaccine to be stable at ambient temperature, so that at the moment, it needs to be kept in a fridge. Even better if it didn't need to be kept in a fridge, if you could just keep it at room temperature. So these are things that I actually had a meeting about just earlier on today about plans for developing this, but it's not something that we can do as quickly as we can intramuscular injection because we already knew how that would work.
Thank you. And Nick Edwards raises a question I think is on many people's minds right now. How concerned are you about viral variants? And especially in Brazil, where we're seeing the impact of one of the latest variants. Someone described it as being like an atomic bomb in terms of the casualties that are filling hospitals. And they seem to be developing quite fast. There's obviously a trade-off in time, isn't there, about how variants develop?
So, I mean, there are a number of different variants, and the one that we're not worried about at all is the one that developed in the UK, so the B117 variant.
The Kent one.
The Kent one, yes, because the later efficacy data from our clinical trials and the recent effectiveness data that we're seeing, that's all with a lot of the Kent virus around, and the vaccine's working very well against that. So we're not worried about that one. The ones that in lab tests seem better able to avoid the antibodies that are induced either by vaccination or infection with the original virus, those are the South African variant in particular, possibly also the Brazil variant. So we started in December thinking about next generation of the vaccine. So it's a very adaptable technology. We just put in a different spike gene sequence and we can make a vaccine against the Brazil variant or the South African variant or the UK variant if we want to. And we started doing that. And we are starting to test those different variants of the vaccine to match the variants of the virus. And that will give us data that will help decide what we should move to next. So it doesn't necessarily mean that for every new variant we have to have a new version of the vaccine, because there's a lot of similarity between the mutations in Brazil and in South Africa. We're seeing the same changes crop up again. So it may be that we have to have one new version of the vaccine, which then works against multiple different variants. But we also have to keep an eye on what's out there and what's coming next. But we have seen that we get good protection against the Kent variant. In South Africa, our vaccine didn't protect so well against the South African variant in terms of mild disease, but we were only able to look at it in protection against mild disease because it was a young population that was being tested in, and nobody in the control group got severe disease. So we can't say if our vaccine could have protected against severe disease. And what we know is that it's easier to protect against severe disease and hospitalization and death than it is to protect against mild disease. So we're optimistic that the vaccine would still protect against at least severe disease with many of these variants.
Thank you. Tim Waite asks, why is a small minority of people not benefiting from the vaccine?
So when we're looking at the over 70s and the over 80s, not everybody is being completely protected, although we do have a high degree of protection. It's partly down to them. So particularly if we're thinking about the care home population, the very frail elderly, their immune system is not really working well. It won't respond to a vaccine particularly well. So that's not really a surprise. And there would be some older people whose immune systems are partially functioning and they don't make a very good immune response. So that's part of it. The level of exposure of virus that you get may have something to do with it as well. If you just get a very small amount of virus causing your infection, it's going to take longer for the virus to spread and cause severe disease, and that gives your immune system longer to respond to it. So I think it's probably a combination of your level of exposure and your ability to make immune responses, may be related to the variants as well in some cases. We know that no vaccine is perfect. No vaccine will ever protect everybody who's vaccinated with it. But I think the vaccines, the Pfizer vaccine as well as the Oxford AstraZeneca vaccine, are showing really high effectiveness in older people, and that's only going to improve when we start to see the data from younger people being vaccinated.
Excellent. There are concerns, this is another question, about a possible vector immunity that could cause just mild body response to the second jab compared to other vaccines, which show really a boost after the second jab. Are there issues about needing to change the vector? A couple of people are asking about this.
So we measure antibody responses against the vector as well. And we've already shown, and we published this, that the level of antibody responses against the vector that you get from the first vaccination doesn't affect the ability to make the immune response to the second vaccination. And the people with the stronger anti-adenovirus antibodies don't make less of a response to the coronavirus spike protein. When people get infected with a human adenovirus, that's an infection that spreads through the body, through the respiratory tract. The immune system has to respond to control that adenovirus infection, and you're left with antibodies against that human adenovirus. What we're doing is very different. We're injecting into the muscle one dose or then 2 doses of an adenovirus that can't spread. So the body doesn't need to make an antibody response against the vector because it's there for a few days and then it's gone. So the level of antibodies that we get against vaccination are very different from the level of antibodies that you get when you've been naturally infected with an adenovirus. And although there is some, it doesn't really seem to have any impact on the immune response in the way that we're using the vaccine. If we were to revaccinate people every 4 weeks, we would start to see a problem, probably, but nobody's proposing that we would do that.
Thank you. Jane Yates asks, thank you so much for such an informative lecture. How easy was it to work collaboratively with the global community towards an equitable rollout worldwide?
Well, working with the global community on the vaccine trials was something that everybody wanted to do. We worked with partners that we've worked with previously. It's really important to work with clinical trialists in other parts of the world who know what they're doing, that can deliver high quality trials, and that's exactly what we did here. To work with partners for the equitable rollout is quite complicated. It's a technical manufacturing process, and it's taken a lot of support from AstraZeneca to all of the different manufacturing organizations to bring them all to the point where they're making exactly the same vaccine derived from the same starting materials that we provide, to the same process, testing it in the same way and getting the same yields that everybody gets. And it does take a while for the new manufacturers to really get this process working extremely well in their own facilities. And what that means is that when a new manufacturer starts, the yield of the vaccine that they get, the number of doses they get per batch, probably isn't very good at the beginning. And then, as with many things, with practice, with just more support, they get better, the yields improve. So it's quite a big undertaking to support all of these different companies to manufacture the same vaccine to the same specifications and get the same yield. So that's taken a really huge amount of effort.
And Paul Kaufman asks, how does the potency of COVID-19 compare with the so-called Spanish flu epidemic, which was so devastating after the First World War and killed 50 million people worldwide also?
So the potency, I suppose what that would mean would be the fatality rate. I'm not sure we were agreed on what the fatality rate for SARS-CoV-2 is now, and it's probably changed with the variants that are out there. In the Spanish flu, that only killed about 1 to 2% of the people infected, but because it infected virtually everybody around the world within the space of a few years, there were tens of millions of hundreds of millions of deaths from that. So you don't have to have a highly fatal virus to cause a very large numbers of deaths when the virus spreads and infects everybody.
Right. Question that a couple of people are asking, both Ruth Silverstone and Jeremy McEwen. Thank you for what you and your team are doing. Will we need to have annual jabs for the foreseeable future?
Well, we don't know for certain yet, because we need to keep measuring people's immune responses over time. And we are doing that with the volunteers who were first in our trials, where they're coming back to us after 6 months, and then they'll come back after a year, and we'll see how their immune response has changed. But we did that with the MERS vaccine that we'd worked on previously, and we saw that a year after vaccination, they still had very good immune responses. So my expectation is that, at least in younger adults, we won't need to revaccinate every year. And I also think that the vaccines, because the variants are not changing very much, we won't need to keep revaccinating because we've got different variants out there, because the variants are really quite similar to one another. But it may be that in older people who are more susceptible to severe disease and don't have such strong immune systems, we may need to vaccinate them more frequently. So we could end up with a situation where once all the adults have been vaccinated with 2 doses, younger people don't need another dose for several years, but older people, maybe the 70+ population, we would be looking to vaccinate more frequently.
Right. Again, a question that a few people are asking, but I'll ask Jill McLaughlin's version. Does the second dose have to be with the same brand of vaccine? So the whole mix and match issue?
Well, in theory, absolutely not. I mean, we've done lots of work in the Jenner Institute on what we call heterologous prime boost immunization. So using one vaccine of one type and a second vaccine of another, and that often works extremely well. In the case of SARS-CoV-2, that needs to be tested. And there are trials going on now with the AstraZeneca and the Pfizer vaccine, giving either one first and then the opposite one second. That's partly just to look at the safety of that approach, because it's possible that with so many people being vaccinated now, when people come back for their second vaccination, it might be the case that the one that they had the first time around isn't available on that day. And so we want to know, would it be a good thing to do to give them whichever vaccine we do have in the clinic, or should they really wait to have the same one again? So that's being tested, and there's no reason why it wouldn't be safe, but it's formally being tested now, and it may result in even better immune responses. So we'll see that when we get the clinical trial data.
Thank you. Jagdev Panisar asks, you mentioned that you have to supply something to all of the labs which are manufacturing the vaccine. What is in this starter kit?
Well, there's quite a lot, actually. So to make the vaccine, first of all, we need the cells, the special cell line, which is derived from a human cell that we manufacture the vaccine on. It has some other changes made to it. And that's produced, those cells are grown in quantity. And so there's what's called a master cell bank. And then from that, you develop the working cell bank. And then you supply these frozen cells to all the different manufacturers. And then we need to supply the stocks of the ChAdOx1 virus itself, which are then used to infect the cells, and the virus replicates and makes more copies of itself. So it's only in this particular cell line that the virus can make more copies of itself. It doesn't do that when we use it to vaccinate. And then when you've got lots of the virus made inside the cells, then you have to purify it. So we have to transfer all of the information about how to grow the cells, how to infect them, how to purify the virus from the cells, and then how to test it. And there are lots of tests that have to be done before you can use a vaccine in people. And those tests have to be done in a very standardized way. And you sometimes need reagents, chemicals, things that you use in those tests, or that you use to understand if the test's working properly. So there's a whole package of information that goes alongside the cells and the virus that you need for the manufacturing.
Thank you. And Michael Carrington raises a question that, again, others are asking. When will we have an indisputable statement regarding the cause, the origin of the virus, do you think?
I don't know that we ever will, and I don't know that it necessarily matters. It's all the way around the world now, and we need to protect against it.
Because one of the things that I read was that a researcher in Wuhan did send the sort of genetic profile very early on to one of your colleagues. Am I right?
Well, so it wasn't directly to us. It was made publicly available on a server that people all around the world could access, and we were able to access it as well.
Right. But obviously, you know, huge amount of collaboration from concerned Chinese colleagues trying to get the world to work on this. Thank you. Right, let's have a quick look at there's so many questions coming in, guys. These are all brilliant. Oh, here's a good one. Paul Milner says, anything more been discovered about the apparently different susceptibility to the virus in minority ethnic populations? It's causing a lot of anxiety.
Yeah. So, well, my job is to develop the vaccine and get everybody protected. And we've tested the vaccine in minority ethnic populations, and we know that it's safe, and we know that it gives very good immune responses. And there's more and more data coming about efficacy and effectiveness of the vaccine as well. So that's what I need to be looking at. So the reason different groups can be more susceptible is either down to genetics, or it can be down to other things, microorganisms in the environment. But if we're talking about people who are all living in the same country, then it's largely down to genetics. People have just inherited different genes, and that goes back through history. So if you're descended from somebody who was living in Europe in the time of plague, your genes will have been selected to be more resistant to plague, because you would have survived, more likely to survive if you have the genes that mean you get through plague. If you were descended from somebody who was not living in Europe at that time, you might have been through, or your ancestors would have been through different selective pressures. And so we all are products of our genes, which have been selected by our environment through our ancestors over decades and hundreds of years. So the diseases that were causing large numbers of deaths in the past, where people were living, shapes our genetics today, and that can then affect our immune response to those diseases now.
Thank you. Richard asks, after all the adult population has been vaccinated twice, which seems really likely in somewhere like the UK, will we be approaching herd immunity?
Well, we also need to, if we really want herd immunity, we would need to vaccinate children as well.
What's your view on that? Because that's also a question being raised about.
Yeah. So at the moment, there are clinical trials, not just with the Oxford AstraZeneca vaccine, but with other vaccines as well. They're being tested in teenagers, and they will in future be tested in younger children. That's for a couple of different reasons. So there are some children that are particularly susceptible to infection that really would benefit from vaccination. So we need to get the data to allow that to happen. But then there's a question of whether we use it more widely. And we know that for flu, if you vaccinate toddlers against flu, it not only protects them, it greatly reduces the number of flu infections that happen in that whole community. And now this doesn't seem to be such an issue for COVID, for SARS-CoV-2, but it's true that we will still have circulation among children if they're not being vaccinated. So it's going to be a complicated decision. Those children would normally be getting infected with seasonal coronaviruses. There are 4 other coronaviruses that infect us and cause colds, but they can cause severe disease and death in very old people, the care home population. This is a new coronavirus that we haven't had circulating before, so we haven't got immunity to. With the ones that have been circulating for a while, kids get infected, they have a cold, they get better, adults might get reinfected. And because that immunity builds up over life, it's not until you get to the very late stage of life and maybe the immune system's not working again that those coronaviruses are dangerous. Now, if we want to get to that stage with SARS-CoV-2, we have to think about how that immunity is going to be built up. And it could be built up by vaccination. It could, in theory, also be built up by infections in the children who are not particularly at risk, but that will allow the virus to continue to circulate, and people who are at risk could then continue to be exposed. So it's a complex decision to make. For the moment, we're concentrating on getting the vaccine safety and immune response data to allow that kind of decision to be made by others.
Thank you. I want to try and fit in 3 more questions if I can. Alan Cutler asks, how does obesity affect the situation?
How does it affect, sorry?
The situation, the whole issue.
Okay, so well, we've heard recently that in countries where that people are much more susceptible to severe disease from COVID if they are obese. There's a general kind of inflammation that goes along with obesity, and so yeah, it's not a good thing to be obese if you're going to be infected with this virus.
Thank you. An anonymous one. As a clinician involved in vaccination, I despair that people are being fed what I see as mischievous data, making them ask for one vaccine over another. I see the vaccines as more or less equivalent, and that these people are being misinformed for political and commercial reasons. I know you have, well, in theory, vested interest, she asks, but do you agree?
I've always said people should take the vaccine that they're offered. The best vaccine to have is the vaccine that you're being offered. I mean, we now have data that shows you can't choose between the Pfizer and the Oxford AstraZeneca vaccine. That's quite clear. They're both working extremely well. And what we need is to get everybody vaccinated as quickly as possible. So people should be taking a vaccine as soon as they're offered it.
Thank you. And Susan, I think this might have to be the last question. How easily have you managed to focus completely on your vital work and ignore all the politics around vaccination in the background?
Well, it's not always easy, but I just don't read the news some days if there's some new row going on. There's always loads to do in the lab working on the vaccine program. So sometimes we just get on with doing the work and leave the politics to somebody else.
Fair enough. Actually, I'm going to sneak in this one from Tony F. Thank you, Sarah. Today on Radio 4PM during an interview, you said a worry was whether people would continue doing what they need to do or would behave as if everything was okay. Could you expand on that?
Well, what we don't want to happen is that with the success we've had of the vaccine rollout so far, and we're seeing a rapid drop-off in case numbers and decrease in deaths, decrease in hospitalizations, we don't want people to think that's it, it's all fine, we can go back to normal now. Because if everybody stops following the guidelines now, before we have a lot of the population vaccinated, we will see a big uptick in transmission, we'll see hospitalizations increasing again, and we also lay ourselves open to more variants forming. So we need to, stick with the plan for now. As the vaccine rollout continues, gradually open up society and not just declare that it's all fine and we can go back to normal living, because we haven't finished the job yet.
No, in a sense, it's a more dangerous time when we think that things are definitely, there's a solution out there, but we're not there yet. I mean, we could go on talking forever, but you need a break. And I think you've answered so many terrific questions. So thank you. Every year, I feel the speakers who give the Rosalind Franklin Medal, all have something important to celebrate. But I think tonight, when we're all not even in the room together because of COVID, I have particular pleasure and honour, quite frankly, in being the one to get to field questions for you. Now, at this time, I would normally be presenting Sarah with the Rosalind Franklin Medal. However, as you may have worked out, there are a couple of somewhat insurmountable problems on this occasion. The first one you can guess, which is we can't all be together, we're all separate, so I can't physically present Sarah with her medal as I normally would at the lecture. But the second problem, which you may have guessed, or probably not know, a software bug at the engraver's workshop has meant that the medal does not yet in fact exist with the engraving on it. We only sadly became aware of this week, but I think we have an image of the medal which people can see, so it will exist. You will get it, and I'm sure that Sarah, you will be receiving it in person next week, and we hope that we might have a photograph or something that we could share with everyone who's been following your achievements and has been following the Rosalind Franklin Lecture. So in the meantime, we're sharing the artist's impression, and it is still my pleasure, even in this weird non-physical way, to award Sarah, Professor Sarah Gilbert, the Rosalind Franklin Medal for her careful, diligent, life-saving work in creating the vaccine, and her ongoing public science communication work, both educating and reassuring the public at this time. If I may ask Sarah, I know it's a really journalistic thing, but looking back on what's happened over the past year, how do you feel?
Well, there hasn't really been much time to think about that because we're still going, we're still working every day, we're still thinking about what we need to do, and it's absolutely wonderful to see the vaccine being used now in so many countries around the world, and seeing that it really is saving lives in the countries where we've used it most. So it's great, but I think it's going to take a while for it all to sink in.
Yeah, no, it is. Well, thank you. That's such an inadequate word. Congratulations again. Thank you for sparing the time to talk to us. Thank you to everyone from around the world who took part in this event, for submitting your questions, for being here. And thank you to Humanists UK for organising the Rosalind Franklin Lecture. Good evening.
Thank you.